Hello, everyone, and thank you for your interest in this presentation about women's longevity and overall health. My name is Luísa Batista. I'm a family physician by training, but I am also a doctor at TejoMed. We are Portugal's first membership-based concierge family medicine clinic, and we are revolutionizing healthcare in Portugal by allowing our doctors, such as myself, to have a list of only a couple hundred rather than a couple thousand patients, which allows us the time to really focus on getting to know our people, on answering any questions that they may have, on researching any information that's useful for them, and of course, on making presentations such as this one. And as a woman, it is especially important to have regular follow up regarding so many different hormonal questions, which makes this kind of support even more valuable. So, if this resonates with you and if you like personalized long term care, please contact us about becoming a member. So, for this talk, I was asked to choose a couple topics that I thought were relevant for women's health. And I chose hormonal health and mental health because I feel that both of these topics, complex as they are very closely tied in with how much access women actually have to longevity to begin with and how well they experience it. So, not just the lifespan, but the health span. So, I'll start with hormonal health and then move on to mental health. And at the end, you will be able to pose any questions that you may want to have answered, and I will answer to you in due time. So, starting with the basics, women are born with all the eggs we will ever have. That is about 1 to 2 million. And of these, only about 4 to 500 will ever manage to mature enough to actually go on to ovulation. And what we sometimes don't know is that the menstrual cycle, as we know it, so as we see it here in this picture that we learned about in school, it's not the full journey of the follicle. It's actually the end part of a months-long process of recruitment that these follicles go through. This is why sometimes we have problems with our cycle or our period and we can't really relate it to anything that happened. Maybe what happened was already a few months ago, a stressful event, a nutritional imbalance, and it's having an effect now. So, going over the players on this cycle that we know or do not know so well, we have four main hormones at play. We have two pituitary hormones, FSH and LH, and we have two ovarian hormones, estrogen and progesterone. So, at the beginning of the cycle, what we have is follicle growth at ovarian level under the influence of FSH. FSH is the hormone that stimulates follicles to grow, and eventually a dominating follicle emerges, and that follicle grows and grows, and as it grows, it releases an increasingly high level of estrogen. And this level will eventually reach a threshold which is critical and triggers a surge in the other pituitary hormone, which is LH. This is the surge that we see here in the graph. And this is also the moment that our egg finally manages to ovulate. So it breaks out of its follicle and it goes on to the uterus to eventually undergo fertilization, if that is supposed to happen. And what stays behind is the corpus luteum. The corpus luteum is one of the body's most important temporary glands. It only exists in women. And then it produces progesterone under the ongoing influence of LH, which still stays around for a little while. And this is especially important because the corpus luteum is the only way we have of producing natural progesterone. So if we don't ovulate, as you can see easily from this explanation, we don't really have any natural progesterone. It is also very important that we do have these two different dominating phases. We have a follicular phase, the beginning of the cycle, that's dominated by estrogen, and we have a luteal phase, the end of the cycle, that's dominated by progesterone. These are two very different and important hormones that we have as women. Estrogen is more of a grower. It's a go-getter. It gives us energy. It makes the uterine lining grow. It gives us bone density. It lubricates our vagina and our joints. It stimulates our production of collagen, thus preventing wrinkles. It stimulates serotonin and dopamine, which prevents mental imbalances. So it's a it's a really very important hormone. On the other hand, we have progesterone. So if our uterine lining just grew crazily under ongoing influence of estrogen, what would happen is that once period came to shed all of that, we would have a very painful and heavy period. And this sometimes does happen. If we have adequate levels of progesterone, which is a stabilizer hormone, kind of a peacemaker, what happens is that the lining stabilizes before getting too crazy. And when we have our period is adequately long and adequately heavy, not too much, and usually not too little either. In addition to that, progesterone is also very important for sleep regulation, mood regulation. It stimulates GABA in the brain, which is related to pain and to mood and to sleep, all of these. It's a natural anti-inflammatory and diuretic. So basically, it's any woman's dream. And again, I cannot stress this enough. We cannot produce it without ovulation. So it is indeed very important that we manage to reach ovulation. So the normal ranges for your menstrual cycle, for the duration of the cycle, the usual is between 21 to 35 days. This number may be slightly higher in teenagers because of a longer follicular phase related to the fact that the pituitary does not yet produce as much FSH. The cycles may vary between 7 to 9 days from cycle to cycle. This is normal. And your period shouldn't be longer than 7 days or heavier than 80 milliliters. So for reference, if you haven't been measuring, a regular size tampon or pad is 5 milliliters. So this would be about 16 of them for the full duration of the period, which should not be more than 7 days. So I don't know if you relate to these numbers, but many of the women that I see in my practice do not. And this is especially true once they reach a further time in the timeline, known as perimenopause. Now, contrary to what many of you may believe, perimenopause is not just a few months before you finally reach menopause. Perimenopause is a very long period that in some women may last up to 8 to 10 years. And it is marked by many fluctuations. It is definitely not a stable decay. So what happens is that our ovarian reserve of good follicles, follicles that get to mature to go on to ovulate, gets less and less, as we saw in the beginning, right? So two different things happen because of this. First, we have a lower base level of estrogen. We don't have as many follicles or such good follicles to produce it. And what happens is that the pituitary decides to secrete more FSH to try and get more estrogen out of the follicles that we do have. And sometimes this works in a counterproductive way, and we actually get estrogen peaks, like too high, higher than we'd wish. At other times, it doesn't work so well because the follicles do not respond as well as they might because they're not as good as they used to be. And so the estrogen is still low, which means that that estrogen at this phase it fluctuates. It's like a roller coaster. It's not a steady decline. On the contrary, we do ovulate increasingly more rarely, which means that progesterone itself does gradually decline. And it's a steeper, more consistent decline, which means that we may have two different scenarios that may fluctuate all through perimenopause. One of them is marked by a simply low estrogen level. And when this happens, it's not very relevant that progesterone is low as well, because as we will see later on, what we want is a good progesterone to estrogen ratio. And if estrogen is low to begin with, then progesterone being low is not as relevant. And the symptoms that we have are mostly related to the lack of estrogen. This is lighter bleeding, vaginal and joint dryness and discomfort, depression, night sweats, and hot flashes, which I'm sure you've all heard about. On the other hand, if we have one of those peaks that I mentioned earlier, where we actually get a bit too much estrogen out of our ovaries, then what we do definitely experience is an imbalance because we don't have enough progesterone to tranquilize this high estrogen. And what happens is that we get kind of the opposite of what we said before. We get shorter cycles, heavier bleeding, longer bleeding, mood swings, anxiety, not so much depression, it's a bit different, sleep disorders, fluid retention. And so in the sense that estrogen fluctuates and the levels of estrogen kind of dictate which of these you will be experiencing, these symptoms may as well oscillate and not at all be a stable decline as some people expect to experience. And finally, by about 45 to 55 years old, we reach a point where we've literally depleted all of our viable follicles. They no longer are able to go on to ovulation. And this is what we actually call menopause. The woman stop, right? So at this point, we stop having progesterone entirely because, again, we can only get it from ovulation. And we don't have any alternative sources. So that's done. And estrogen itself decreases very sharply. We still get some from fat tissue, but this is a much smaller scale than what we used to have during our reproductive years. So menopause is definitely mainly marked by symptoms of lack of estrogen, which is the first type that we talked about before. So this beautiful lottery, this lucky win that we get when we reach this age, includes fun things such as loss of bone density, which makes it so much easier to break a bone when we fall, skin thinning and wrinkling, which creates the skin aging that we know so much about and try to fight every day. It gives us uncomfortable sex because the vagina, even if we are aroused, it just will not lubricate. We get newfound arthritis or arthrosis because we no longer lubricate our joints as well either. We may be depressed, and of course, the night sweats and the hot flashes. And the fine print for all this that sometimes women are also not told about is that some of these symptoms may actually last for 4 to 10 years. It's not the same for every woman. Some women go through menopause very smoothly, but if you are very, very unlucky, you may actually have, theoretically, 10 years of fluctuating symptoms of perimenopause, and then 10 more years of this beautiful lottery that we see here. So how do you know that you've reached this wonderful stage of your life? Well, sadly, this is the bad news. Even with all the advances that we've been doing in science, this is still a clinical diagnosis at this point. So basically, we just know that 1 year after your last period, when you reach that point, we know that 1 year before, that means at your last period, you reached menopause. So it's a retrospective diagnosis. We still don't have any other way of being absolutely sure. We do have some guessing game that we can do. We can ask our mothers, because apparently age at menopause seems to be up to 50% hereditary, so we may get some information out of that. But there are many factors at play, and this is, again, not very accurate, not even 50%. And we can do testing. We do have some markers, but these are still not 100% reliable. None of them, even the newly developed ones. So what we do have are markers that can tell us that we are most likely approaching menopause, or that we have most likely already crossed the threshold. But again, this is never 100% certain. So especially in regards to contraception, it's good to actually wait for the clinical diagnosis so that you can be sure that you no longer need to be careful. And we get to the point where I tell you some good news, right? Because it can all be bad. So it's actually not all fine and good. I think we've all established that. But what can you do about it? So to begin with, and to help you, I will try to explain the concept of estrogen dominance, which is still not a, widely clinically recognized term, but it definitely exists. And it's not a problem only in perimenopause, so it may be helpful to you, even if you are years away from that age. So estrogen dominance, which means that for a certain level of estrogen, we have too little progesterone to oppose it, which is mostly relevant in the luteal phase, where we expect to have the opposite. We want more progesterone and less estrogen, can be the cause or worsening factor of many conditions that you or someone you know may be experiencing, like PMS, heavy or painful bleeding, PCOS, endometriosis. And this is very common nowadays, perhaps more than in our mothers' days or our grandmothers, because our current lifestyle highly favors the buildup of excess estrogen. Estrogen is a very good thing, but too much of a good thing, you know what they say. So what can you do to tip the scale and get yourself out of this vicious cycle? well, you can do two different things. The most important one and the basis should always be to support your own body in metabolizing and adequately excreting the excess estrogen that you may be accumulating. This requires making sure that you have an adequate intake of vitamins and minerals, which are cofactors for the metabolism of estrogen, such as B vitamins, zinc, magnesium. It involves having a healthy microbiome that can adequately excrete estrogen, and fiber helps with this. Calcium D-glucarate is also a very good supplement for this. And you should be avoiding alcohol and some inflammatory foods such as sugar, dairy, especially cow's dairy, wheat, and vegetable oils. Most of them, olive oil is a bit of an exception, because all of these are substances that our body is very naturally reactive to. And inflammation creates a chemical environment that really signals estrogen production and build up. So you do want to avoid this. This is not the same for every woman, and in some women, one of these things will not make as much of a difference as another, but it's definitely worth trying it all. And you also want a healthy fat mass level. So you don't want a fat mass so low that you can't even ovulate, because you need fat mass for your sex hormones to work properly. But you don't want too much of it, because fat cells is where estrogen is converted into itself from its predecessor. So if you're doing this too much, you end up with too much estrogen. And of course, if this hasn't worked, or if you want to give it an extra push, you can try to actually give progesterone a push directly. And you have two ways of doing this. You have a natural way, which is a supplement, chasteberry, a natural plant, which produces FSH and relatively increases LH, which results, of course, in a relative increase of circulating progesterone. Or if this is not enough, because in the end, this is a natural way that takes advantage of your body's natural work, and your body may not be working well to begin with. If that's not enough, you can go straight to bioidentical progesterone. This is a copy of our own progesterone. It's like ours. That's why it's called bioidentical. And you can get it from a pharmacy and compensate directly the lack of progesterone that you're experiencing. And for women with regular cycles, I recommend cyclic therapy from ovulation to menstruation. And for women with irregular cycles, especially as they near menopause, I recommend continuous therapy. But this is done on a case-by-case basis, and I really like to work with women on which is more appropriate to them. And now, maybe the most important part of this presentation is HRT. HRT is the answer to a lot of what we've been talking about, and sadly, after 2002, which is when a study came out that revealed some risks that it could have, a lot of women are not getting adequate access to the help that they should be receiving. And the sad thing is that the media is a bit at fault for this, because what they forgot to mention about this study, which got totally blown out of proportion, is that the average age of women participating in the study was 63, which is far too late to start and sometimes even to end HRT, and it's much riskier. Second, many of these women had pre-existing conditions which made them more prone to breast cancer, cardiovascular events such as stroke and clots, and so they should never have been studied in this way with no control. And third, and perhaps most importantly, the hormones that they were taking were horse hormones, in particular horse estrogen. That is not a joke. It's literally what was happening back then. And of course, it's not what's happening today. So the bottom line of this, and the truth of the matter, is that HRT is something that every woman deserves, and most women are eligible for. The rare exceptions are women that have a personal or family history of hormone-sensitive cancers, such as breast, uterus, ovary. And we definitely don't want to start too late or end too late, because that does increase risk. But apart from that, you should totally be looking into this, especially in the beginning of your symptoms. Like, the sooner, the better. HRT makes you feel better, and it actually decreases your risk of a lot of serious diseases, cardiovascular, depression, dementia, you name it. So the golden rules for you to have in mind when you talk to your practitioner about this is, first, always ask for bioidentical, because we do have bioidentical versions of all these hormones now, there's no point to do otherwise. Second, do not take unopposed estrogen. Some women are proposed estrogen only, HRT, because they no longer have a uterus, and because supposedly progesterone is only important if you still do have one. This couldn't be farther from the truth, because as we saw before, if you have an unbalanced ratio of estrogen and progesterone, you will be experiencing symptoms as well. So maybe this would change your symptoms, but not necessarily rid you of them. So do not do this. And third, avoid oral estrogen, because it has a higher risk of clots compared to transdermal patches, to patch approaches, for example, and no real advantage. Testosterone is a third hormone that has been proposed as part of HRT by people such as Peter Attia, and I do see very well the rationale for it. Basically, when you replace estrogen, so you raise your levels of estrogen, you upregulate the natural production of sex hormones transporters, because you need more of them, because you have more sex hormones, in this case, estrogen. What happens is that these transporters are not estrogen specific, so they also bind testosterone. So you will end up binding your natural free testosterone more than you should be. Like it was not supposed to be happening. And you may be thinking that you don't need testosterone for anything, but actually it's where a good part of your libido and your energy and your muscle mass and strength comes from. So you definitely do want to make sure that you have adequate levels, especially if you are experiencing these symptoms like a lack of libido, a lack of energy, bad mood, etc. You should just be sure that you are only doing it after you are already doing the other female sex hormones. Otherwise, you'll just be on testosterone, which is not ideal, I think. And as an FYI, you can get it as a gel, and the place you apply it may grow some hair, so be creative. And my final point on hormones is about hormonal contraception. This is also an important message, because I think hormonal contraception has been painted the villain by very respectable people that I read and love. But I do think it makes more sense to give both sides of the matter, because I think in every situation, the villain is misinformation. When you don't know why you're doing what you're doing or what it could be doing to you, that's where you may fail, or your practitioner may fail. And it's important to know the whole picture before you make a decision. And if you are informed, then any decision is legit, right? So the problem with hormonal contraception is not so much the potential clot risk that is sometimes talked about, because in fact, that is not half as concerning as you may be thinking. It's a bit of the same as HRT. It's very risk dependent, like pre-existing risk dependent. The real problem is the deprivation that it causes from your natural hormones, because at this point, we cannot do contraception with bioidentical hormones. The ones that can do it are all synthetic. And synthetic hormones are very different from our natural ones in that they are, well, the same in some senses, of course, otherwise they would not work, but they are very different in other ways. So with synthetic estrogen and progesterone, you may have changes in mood, changes in sleep, etc., changes in libido, you name it. And this is true even if you're taking only progestin contraception. And they do stop it. So taking the synthetic ones is not the same as having natural ones, and stops you from making your natural ones. So this is something to consider in what concerns your quality of life. The other reason that you should consider not doing hormonal contraception is if you're doing it for the wrong reason. So if you got started on the pill in your teenage years or your 20s because you had irregular periods, then it doesn't make sense, because irregular periods are normal in those ages and should not be treated in this way or any other. So it makes no sense. These hormones are not the answer for PCOS and acne and hirsutism. They are just band-aids for them. So if these are the reasons that you're on it, maybe consider getting off it. On the other hand, hormonal contraception is extremely effective and it's reliable, and there are many options to choose from. And it's easier to do than a calendar method, for example, and more pleasant than a barrier method such as a condom. So if you know all of this and you still wish to try it, then I think you should have access to it as well. As with everything in life, I think the key is information, communication, and empowerment. You may send your questions my way. I will do my best to answer them. And I would like to once again invite you to meet me, eventually join the service if you haven't yet, because I am here, and from woman to woman, I think you deserve the best. And I hope to be able to give you the best. Thank you so much for your attention.